Hello everyone and welcome to chapter 11. This chapter covers a ton of information, so I'm going to try to be as quick as possible with giving you the most meat of the information. And I think I'm going to provide you with some supplemental information, some videos that can illustrate in the best way possible some of the functions of these bodily systems. There is a ton to learn in a short amount of time, but luckily as massage therapists, we're not doing surgery on the cardiovascular system, nor are we in desperate need to know every single working facet of the immune system. But there are definitely things that we do need to know for the safety of our clients and for our own general knowledge of the human body, considering you're going into the practice of manipulating the human body. Now, we're going to start chapter 11 with the physiology of touch. The skin is the most sensitive of our organs. It is the home of the touch receptors of the nervous system. Touch is one of the 5 basic senses that you learn in kindergarten, along with taste, sight, smell, and hearing, but it truly expands the ways in which we experience the world. Touch is the first sense to develop in the embryo, and the need for touch remains throughout our entire lives. As massage professionals, we touch our clients, and the skin is our contact point. Therefore, we must understand the effects of skin stimulation. We can survive without sight, hearing, taste, and smell, but without the ability to feel, we are in constant danger. Without the ability to feel pain, many of those afflicted don't even survive childhood. They have no recognition that something dangerous has occurred to their body. But those who have a complete loss of the sense of touch actually can experience a psychotic breakdown. Not being touched can be life-threatening and can contribute to a condition called marasmus, wasting away, especially in infants, the elderly, and those with weakened immune systems. There are multiple studies that have been done and some pretty horrific experiments done in adoption centers in Eastern Europe about the lack of touch and children wasting away from lack of physical contact. So as a survival mechanism, touch obviously alerts us to danger. This can be done in variations of temperature, vibrations, and pressure received by millions of sensory receptors in the skin. So there's about 1/3 of the 5 million or so sensory receptors in just the skin of our hands. The fingertips alone have more than 1,000 nerve endings per square inch, and the lips and tongue have even more. I want you to look at your keyboard right now and imagine licking it. Your tongue already knows what that feels like. The brain is an interesting thing, and sensory receptors send signals to the brain. And once you know what something feels like from your fingertips, the rest of your body knows as well. The human brain has evolved with 2 distinct but parallel pathways for processing touch information. The first pathway, which is part of the sensory pathway, is called the primary somatosensory cortex. This is the first region to be hit by the experience of touch, which gives us the facts about touch, such as vibration, pressure, location, and fine texture. And the second pathway processes social and emotional information, determining the emotional content of mostly interpersonal touch using different sensors in the skin. This pathway activates brain regions associated with social bonding, pleasure, and pain centers. Because of the separation of the 2 pathways used for processing touch, certain brain disorders cause separation of the physical sensation of pain from its emotional impact. So too can the pleasurable aspect of touch be removed from the actual sensation.
Human interpersonal touch is crucial. It's social glue.
I think we underestimate how important touch actually is in our social interaction.
Human touch is key to our survival. It's in our DNA.
Touch is deeply under-researched. There are probably 100 papers on vision for everyone on touch. We tend to take touch for granted.
Touch relies literally on the whole of our skin. It's the organ of touch. But what happens when we touch other people, and why is that special? Touching other people is processed by the brain with different mechanisms. We discovered very late, only in the 1990s, that in humans we have a specialized set of cells in the skin which then travel with specialized pathways to particular parts of the brain. And this system is called the C-tactile system.
The hand strokes of parting the fur sends this signal to the brain saying, you're in close physical contact with your best friend here. And what that does in the brain is trigger the endorphin system. We feel very relaxed and, particularly important, trusting in the person we're doing this activity with. And that creates this sense of friendship. Light, slow stroking at exactly 2.5 centimeters a second.
This is the caress that we are hardwired to like.
It's comforting.
What happens here then?
So the cuddle sessions take place at one of the pods. Cuddle therapy involves hugs, stroking, squeezes, all sort of forms of platonic touch. It's a very simple practice, yet it can actually have rather powerful effects on people.
It can stabilise their heart rate, it can improve their weight gain, and some studies for low birth weight babies even suggest that the time they stay in hospital can be reduced if they have lots of touch stimulation. It's really forming the first part of social bonding.
Which is why I say, if you really want to know how somebody feels about you, don't listen to what they tell you, just feel how they touch you.
If we have a situation where we're not able to touch the people in our daily lives that we normally touch, it's not like everything's going to fall apart instantly, but our feelings of connection, of empathy, of trust will slowly degrade.
Anybody who I care about, you get a hug. So my biggest struggle is not being able to hug my mum, to wash her hair, to do all the things that we do, bonding, paint her nails, I do her feet for her. That one broke my heart. Still, when I think about it, I could cry.
If you deprive an animal of touch, the animals become literally sick. Both in the mind, they develop a lot of anxiety, and also they live less and they're less healthy in the long term.
The whole social concept of touch is really changing in society.
Does it feel like the pupils are kind of learning not to touch?
It does feel a little bit like that, which is sad.
When people during lockdown were exposed to films where there was natural touch, people had a jump. They were started talking to the TV. No, you can't do that. So that's a good sign of how quickly we learn to inhibit ourselves.
I don't think you'll see people interacting in the same way that we did before the pandemic.
I find it very unlikely that we would ever lose the sense of importance of touch. You should never say never when it comes to evolution, but it will all depend on whether other forms of behaviour that allow us to trigger the endorphin system in the brain, to create friendships, really start to work better or more efficiently than physical touch. And I suspect that's unlikely unless we give up all notion of having romantic relationships.
I think the future should be hugs all day. All day, every day.
Thanks for watching. If you enjoyed that, be sure to check out these videos next. And if you haven't already, hit the subscribe button and click the bell to get a notification each time we upload a new video.
The importance of human touch. Human touch has a dramatic effect on health, and it starts from birth. Babies who are touched more cry less, sleep better, and have better brain development. One study even showed that 10-year-olds that had been held more by their mothers as infants had less stress hormones when facing anxiety-producing situations. As we grow into adulthood, the amount we touch others and the amount we are touched by others dramatically decreases. This can have a major impact on overall health, as touch is an important part of our emotional well-being, contributing to our mental health as well as improving physical health. Some of the benefits of touch include garnering trust between individuals. Touch is a form of communication, and by allowing someone to touch you, you're communicating to that person that you trust them. Touch can reduce loneliness. The touch of another person can make you feel safe and not so all alone, improving your self-confidence and creating bonds and connections with others. Being touched regularly can decrease stress, which by itself can improve immune system function, and in some people, regular touching can increase white blood cell production, which improves health and strengthens against disease. Some research indicates that being touched regularly can also lower blood pressure, lower heartbeat, and help you recover from illness quicker. Regular touch is also vital in loving relationships, as happily married couples report being touched more than not so happily married couples. These are just a few of the benefits of touch. And as more and more research on the subject of touch is being gathered, it's all showing how important human touch is to mental and physical health. There are even people that go through such long periods of not being touched that they make appointments at the doctor's office just to be touched.
All right, so your assignments have a lot of information about the skin. You've got some extra videos about the skin and how it's made, but I need to cover the skin. I mean, you are touching the skin as massage therapists. We need to get to know the skin. The skin is the largest and heaviest organ of the body, and there's two major layers. We have what's called the epidermis and the dermis. The epidermis is the outer layer of your skin. It doesn't have any nerve endings or blood vessels, and it has sublayers called strata, what we usually call your layers of skin. Most areas have four layers, but areas subject to pressure or friction, like the soles of your feet, the palms of your hand, have 5 layers. In all areas, the outermost layer is called the stratum corneum. That is the very uppermost layer of the epidermis. That is what you are putting your hands on as a massage therapist. This layer is made up of 20 to 30 layers of flat, keratin-filled dead cells that are constantly shed and replaced from the layer deep to it. Welcome to the majority of the dust in your house that is shed skin cells, as well as like lice, poop, and other things. But that's another conversation for another horrifying story. But most dust is actually shed skin cells from the humans that inhabit a place, in addition to dust or dirt and poop. But aside from that, this is what sloughs off your clients when you're working on them. I cannot count how many times I have been giving a deeper pressure effleurage strokes, not light pressure, and not quite myofascial either, going a little bit quicker so that there's friction, like a semi-fast, firm forward stroking motion so that there's a lot of friction and there's some skin drag created. And within 10 minutes of doing this type of work, I will have rolled balls of dead skin literally congealing with the lotion. It's almost like I'm peeling off the top layer of their skin. So if that starts to happen to you, don't freak out. You are sloughing off their stratum corneum. There's an innermost layer called the stratum basal or basal, depending on where you're from and how you want to pronounce it, which produces a continuous supply of new cells. These new skin cells just keep being created, and as they push up, the old ones slough off the top. As these new cells develop and mature, they move up through the layers until they reach the top and are shed. This process takes about 2 to 3 weeks. This lower layer also contains melanocytes, which produce melanin, a pigment that colors the skin, which we will talk about a little bit later. It is fascinating stuff. Keratin is produced in the epidermis by, some people say keratinocytes. I say keratinocytes because we say keratin, but you'll hear a lot of anatomists say keratinocytes. Keratin is the fibrous protein that protects the skin and makes it waterproof. Your dermis is the layer of skin deep to the epidermis. So it is below the epidermis. It is the sub-layer below. It is deep to the epidermis. So your dermis is thicker than the epidermis, and it's composed of dense connective tissue that contains collagen and elastin fibers, which provide a lot of the structure and the strength of the skin. If we didn't have that dense connective tissue sort of holding everything together, we would sort of be a gelatinous bag. It would be pretty gross. If you have ever seen that honeycomb pattern in cardboard, sometimes when you have like an inch thick piece of cardboard and you rip it open, and instead of being solid, it's in like a honeycomb pattern on the inside. That is sort of like how the the collagen and elastin fibers are inside of that dermis to help give us that firmness and that structure, because the dermis contains a lot of our essential parts of the skin. By functioning parts, I mean things like nerves to detect pain, our sweat glands, our oil glands, our arteries, our veins, our sebaceous glands, again, oil glands, pressure receptors, your touch receptors are here, your hair follicles are here, and this is where pores on the epidermis go down into, is into this dermis layer. So we can't just have your nerves being collapsed into your hair follicles, being collapsed into your veins. This collagen keeps everything upright. Now, even though they're super firm, they're arranged so that the skin can still be wiggled and moved in several directions. Stretch marks result when these collagen fibers are overstretched. The top layer of the dermis forms into ridges and presses up into the epidermis to create our fingerprints, which is pretty cool. Hair, sebaceous, and sweat glands and nails all originate in the dermis, like I said. All of our essential skin parts for touching, for feeling, for secreting, for growing, they're all in the dermis. And they push upward through the dermis. Either the hair shaft pokes through, sweat comes through the pores, blood vessels and nerves, again, are also found in the dermis. This is an image from your book that shows the structure of the skin. All right, so what's under the dermis? We have the subcutaneous layer, which consists of loose connective tissue and adipose tissue. This layer is also known as the superficial fascia. It attaches to our muscles and to our bones. That subcutaneous layer is not actually a part of the integument or part of your skin, because it contains loose connective tissue, though, that attaches to the dermis It's usually described along with the integumentary system, which is why we're talking about it. But we have covered fascia before, and we have covered adipose, but we're just touching on it again because guess what? Fascia is what connects everything. Like I told you guys before, it's the Ziploc bag that contains everything in it. And all of those ends of all of those bags are all melted together. It's all one giant bag with multiple compartments. In fact, that brings us to the interstitium. There's a layer of tissue below the surface of the skin that before was thought to be dense connective tissue. However, some more recent research using a new technology has revealed that this layer of tissue actually is a body-wide interconnected system of fluid-filled compartments. It looks like the spaces containing the interstitial fluid are present in dense connective tissue and exist in more areas of the body than what we had previously realized in Western medicine. This network of fluid-filled spaces is located everywhere tissues expand or compress as part of the natural function. The physical structure of this tissue consists of fluid-filled spaces supported by a lattice of collagen lined on one side by what appears to be a type of stem cell. These cells help make collagen and can aid in wound healing. They also contribute to conditions associated with inflammation and aging. The research out there right now on the interstitium is still evolving and completely new in the realm of medical science. So I promise you, if you look up articles today compared to 6 months from now, they are probably going to differ wildly if they continue to do research into this. Maybe it's time to really pay attention to all of our anatomy trains and all of our teaching about fascia and pull some of that information from the Eastern philosophies. Your chapter continues with appendages of the skin, all of the functional parts of your skin, your hair, your nails, your sebaceous glands, your sweat glands, your mammary glands, and also your skin color. So please check out those pages. Check out stem cells, wound healing, and scar tissue. If you find this interesting, unfortunately your textbook doesn't cover it in detail. We do talk about wound healing and scar tissue a little bit more deeply in your pathology class. But massage therapy and scar tissue is absolutely a fascinating topic, at least to me. I could talk about it for hours. If you are interested in getting some more information about massage and scar tissue, let me know and I will try to locate some resources for you on that topic. Another thing that we should touch on is skin color. Skin color is created by combinations of pigments in the skin and in the blood flowing through the skin. These pigments are melanin, keratin, and hemoglobin. Melanin is found in the epidermis and it ranges in color from yellow to black. Melanin makes up most of our skin color, and all of us have the same number of melanocytes or melanin producing cells, but the amount of melanin produced depends on genetic factors and exposure to ultraviolet light. This is how people who have lighter complexion can appear darker after being in ultraviolet light or tanning in UV tanning beds or spending time out in the sun. Those cells produce more melanin in response to the exposure to the UV light and become darker in tone. Melanin is a natural sunscreen that protects us from those ultraviolet rays by darkening our skin, and this is an adaptive homeostatic function. Freckles, moles, age spots, and keratoses result from increases in the melanin concentration or from changes in the melanocytes. Keratin, or keratin, depending on where you're from and how you want to pronounce it, is a yellow pigment found in the dermis that naturally gives the skin of some individuals a yellow tint. If plant foods containing keratin make up a large part of a person's diet, keratin can accumulate in the skin and adipose tissue and give the skin a temporary yellow or orange color, especially on the face and palms. I personally have a yellow tint, and I have spent quite a bit of time eating yellow and orange foods before. And as a lighter-skinned individual who is already slightly yellow, I can say this is indeed true, as my hands and the skin around my eyes turned yellow enough that I was concerned about jaundice, which is the skin turning yellow, well, typically your eyes, from a liver condition, but I was concerned, and no, it was my diet and my natural yellow tint. Hemoglobin is the oxygen-carrying red pigment molecule in the blood. In people with light skin, the color of hemoglobin shows through as pink. The color of skin can also indicate a pathological condition or disease. For example, a blue tint to the skin is called cyanosis, or a condition caused by defective or deficient oxygenation of the blood. Similar to how your veins appear blue through the skin, the same is of those with cyanosis. Your veins have deoxygenated blood, and you have less oxygen in your blood at the time, you can appear blue. A yellow gold color of the skin may be a result from jaundice or liver disorders. A bronze or metallic hue is often a sign of Addison's disease, which is a hypofunction of the adrenal cortex. And black and blue marks on the skin, or bruises or hematomas, result when blood leaves the blood vessels and clots in the surrounding tissues. Constant bruising can also be an indication of vitamin C deficiency or a blood clotting disorder, which we will cover greatly when you take your pathology course. Another color indicator of the skin is pallor or whiteness of the skin. That can be caused by emotional factors. We call this the blood leaving the skin. Ischemia is a lack of blood. And when there is ischemia in the skin, your book does not mention this, but your pathology class certainly will. That is when you have no blood in the area and the skin appears abnormally white or exceedingly light compared to other areas. The skin actually contains as much as 5% of the total blood volume in your body.
When ultraviolet sunlight hits our skin, it affects each of us a little differently. Depending on skin color, it'll take only minutes of exposure to turn one person beetroot pink, while another requires hours to experience the slightest change. So what's to account for that difference, and how did our skin come to take on so many different hues to begin with? Whatever the color, our skin tells an epic tale of human intrepidness and adaptability, revealing its variance to be a function of biology. It all centers around melanin, the pigment that gives skin and hair its color. This ingredient comes from skin cells called melanocytes and takes two basic forms. There's eumelanin, which gives rise to a range of brown skin tones as well as black, brown, and blonde hair, and pheomelanin, which causes the reddish browns of freckles and red hair. But humans weren't always like this. Our varying skin tones were formed by an evolutionary process driven by the sun. It began some 50,000 years ago when our ancestors migrated north from Africa and into Europe and Asia. These ancient humans lived between the equator and the Tropic of Capricorn, a region saturated by the sun's UV-carrying rays. When skin is exposed to UV for long periods of time, the UV light damages the DNA within our cells, and skin starts to burn. If that damage is severe enough, the cell's mutations can lead to melanoma, a deadly cancer that forms in the skin's melanocytes. Sunscreen as we know it today didn't exist 50,000 years ago. So how did our ancestors cope with this onslaught of UV? The key to survival lay in their own personal sunscreen, manufactured beneath the skin, melanin. The type and amount of melanin in your skin determines whether you'll be more or less protected from the sun. This comes down to the skin's response as sunlight strikes it. When it's exposed to UV light, that triggers special light-sensitive receptors called rhodopsin, which stimulate the production of melanin to shield cells from damage. For light-skinned people, that extra melanin darkens their skin and produces a tan. Over the course of generations, humans living at the sun-saturated latitudes in Africa adapted to have a higher melanin production threshold and more eumelanin, giving skin a darker tone. This built-in sun shield helped protect them from melanoma, likely making them evolutionarily fitter and capable of passing this useful trait on to new generations. But soon, some of our sun-adapted ancestors migrated northward out of the tropical zone, spreading far and wide across the Earth. The further north they traveled, the less direct sunshine they saw. This was a problem, because although UV light can damage skin, it also has an important parallel benefit. UV helps our bodies produce vitamin D, an ingredient that strengthens bones and lets us absorb vital minerals like calcium, iron, magnesium, phosphate, and zinc. Without it, humans experience serious fatigue and weakened bones that can cause a condition known as rickets. For humans whose dark skin effectively blocked whatever sunlight there was, vitamin D deficiency would have posed a serious threat in the north. But some of them happened to produce less melanin. They were exposed to small enough amounts of light that melanoma was less likely, and their lighter skin better absorbed the UV light. So they benefited from vitamin D, developed strong bones, and survived well enough to produce healthy offspring. Over many generations of selection, skin color in those regions gradually lightened. As a result of our ancestors' adaptability, today the planet is full of people with a vast palette of skin colors. Typically, darker eumelanin-rich skin in the hot, sunny band around the equator, and increasingly lighter pheomelanin-rich skin shades fanning outwards as the sunshine dwindles. Therefore, skin color is little more than an adaptive trait for living on a rock that orbits the sun. It may absorb light, but it certainly does not reflect character.
All right, so this next image I think is pretty cool. From your book, it's a little simplistic. I mean, it's a cartoon drawing, but it shows in the different pathological conditions of the integumentary system, your skin, how deep some of these various pathologies go. Like if you have a macule versus a papule versus a vesicle or a pustule, how deep into the epidermis you go. It does show here that this ulcer eats through the epidermis and exposes your dermis. In the cases of like decubitus ulcers or like bed sores where people are stuck in positions on pressure points, like their bones like sitting down constantly in wheelchairs, backs of the shoulders, shoulder blades, back of the buttocks and hips in side-lying positions laying down. In a stage 4 ulcer, they can actually eat all the way to the bone. But again, we will discuss that in detail in the skin pathologies in your pathology course. So I don't want to dump a ton of this information on you, but it is time to start talking about the basics of skin pathologies. Just going through the rundown from your book, we have acne, boils, cellulitis, which, by the way, can be absolutely deadly. Cellulitis is a rapidly spreading acute bacterial infection of the skin, usually found in like the legs. Bacteria enters through the damaged skin. Your book states it's usually because of complications of diabetes or poor circulation, but a very grand amount of time, it's through a small wound. And it just looks red, and it's hot, and there's swelling and pain because it's inflamed. So it is very easily mistaken for basic inflammation or just another type of dermatitis or some type of infection. Please familiarize yourself with cellulitis and its warning signs for sure. Your book covers a little bit on viral skin infections. You need to be aware of chickenpox, herpes simplex. These 2 images are from your book and show some of the more common things that you may see come in through the office. I highly suggest you look on page 588 and read through. There's not a ton of information here. It's just enough to get you introduced to these things: fungal infections, bacterial infections, viral infections. Just familiarize yourself with what these look like and what they can potentially be. Moles, what is a callus, what is a corn, a sebaceous cyst. These are all things that you need to be able to recognize. A skin tag. You will definitely be working with instructors in the clinic. You will be instructed on how to look out for these things as you're working on bodies. So don't get terrified now that you need to learn all of this. You will get it. You will get it in pathology in detail. I just want you to read over like 5 or 6 pages in your chapter and get yourself really in tune with the fact that there is a multitude of things that appear on the skin, and they all look very similar to each other, and about half of them are contagious. I'm going to put some brief excerpts of other educators and doctors, mostly dermatologists, that have recorded some of these symptoms with images so that you can see what these look like. Please either read along in your book or look them up if you are interested. And absolutely study your ABMP, Integumentary system exams, please. I highly recommend that you do that one several times and take the big practice exam on that one. This is something that you want to start focusing on now and throughout the rest of your school career, not just for MBLEX, but because you are touching people's skin all day long in your career. Your hands are touching their bacteria. Their dead skin cells are coming off in every crack and crevice of your fingernails, in any open section of your cuticles, underneath your nail beds, into every crack of your own skin. So please really get to know what you're so intimately touching on another person.
So what I did the other day was I made a big mistake and Googled skin conditions. I Googled melanoma, and this is what I saw, pictures like this, and I nearly fell off my chair.
Yes. So these are various skin conditions that we see relatively commonly in my dermatology office. So I can walk into a clinic with 20 patients and I could see probably every single one of these in a day. So these are very, very common.
How do we know what to look for when we're checking our skin?
In dermatology, I talk about the A, B, C, D, E. And what does that stand for? So the A is for asymmetry. So you should be able to take that mole and cut it in half. And no matter which way you're cutting it, the 2 sides should be mirror images. The B is for border. I should be able to tell exactly where that mole begins and ends. You want a mole that has a nice, round, sharp border. C is for color. It's normal for patients to have a lighter and a darker mole, but I want them to be all one color. Our 4th one is D for diameter. I like things that are smaller than about 6 millimeters, which is roughly the size of a pencil eraser. E is evolving. So let's say you have a mole that is changing. So it's changing in size, it's changing in shape, color, if it's bleeding. You know your skin. So if there's something that just doesn't look like the rest of your spots, that's something we want to look at.
Now that we know when that spot just might deserve a second look, let's give it a name. Starting with the scary one, skin cancer.
Let's start with the basal cell. We diagnose more than 3 million of these a year here in the United States. A lot of times it looks like a pimple or a bite. If it's a pimple or a bug bite should be gone within 4 to 6 weeks.
Right.
Anything that's sticking around beyond that, let me take a look at it. So this one is what we call a squamous cell carcinoma.
Okay.
These, in contrast to the basal cell, which is kind of smooth and shiny looking, it's a little crusty.
Up next, shingles.
So shingles is caused by a virus. It's called the varicella virus, and it's chickenpox. So you get these itchy kind of blisters all over the body, and they go away, but your body never fully gets rid of the virus. It's just kind of hibernating. And then when it reactivates, it travels along that nerve up to the skin.
This one looks familiar. This looks like several sunburns I've had over my lifetime.
Yes. Any tan is a sign of sun damage. So really the safest tan that you can have is a spray tan. It can really happen in anybody. I think one of the common misconceptions is it can only happen in fair people. I do recommend sunscreen for everybody, something that has a broad spectrum, SPF 30 or higher, but the key is that you're using enough of it. I tell people a shot glass for the whole body.
Psoriasis and eczema are often confused, but here's the difference. So psoriasis is something that kind of flares up every now and again?
Correct. So people have a genetic predisposition to it. Here you can see on the front of the knees and here's on the elbow, raised plaques. And a plaque is basically just a raised skin lesion. This same inflammation, the same irritation that you're seeing in the skin can also happen in the joints. You can actually lose functioning of those joints. Psoriasis, it increases your risk of heart disease. So this is eczema. And so the fancy word for eczema in dermatology is atopic dermatitis. Dermatitis itis means inflammation, derma means skin. So eczema tends to travel in families that have a history of asthma, seasonal allergies, and eczema. And the problem with eczema, it's really itchy. And so the kids will itch and itch and itch. And then as we get older, it shifts to other locations. So we'll see it in the crook of the elbow, we'll see it behind the knees, sometimes around the neck, on the eyelids and whatnot. So moisturizers, cooler showers, gentle soaps.
Lots of things to know about.
Lots of things to know about.
Lots of things to get checked. So see the dermatologist once a year?
Once a year. I would, especially if you've had a lot of sun exposure, tanning beds, blistering sunburns, I would see a dermatologist, at least check in, and then they can tell you 1 to 2 years or go from there.
Great, thank you so much.
You're welcome. Thanks for having me.
Check this little thing right here on my face.